Hello everyone, my name is Daisuke Tsuruma from Kyushu University, Japan. Today, I'd like to talk about CT imaging of gastric cancer, its role, process, and advantages in clinical practice. Here, I will discuss the role of CT in gastric cancer and the diagnostic process. I will then move on to practical CT imaging. The role of CT in gastric cancer is mainly for staging. It allows us to visualize the whole abdomen in a single examination. Endoscopy and EUS are good for early cancers, but CT is much more useful for advanced cancers. The main aims of CT staging are to evaluate the depth of tumor invasion, to detect lymph node metastasis, and to search for distant metastases such as in the liver or peritoneum. Accurate CT staging supports clinical decision-making and improves patient outcomes. For accurate staging, several techniques factors are essential. Multi-slice CT, iodine contrast agent, and three-dimensional CT reconstruction. These techniques together provide high-quality and comprehensive diagnostic information. Multi-slice CT has several advantages. It allows rapid scanning, thin slices, and high spatial resolution. This minimizes the motion artifact and enables detailed assessment of the stomach wall and surrounding structures. It also provides the raw data necessary for 3D reconstruction. The use of iodine contrast is essential. It enhances visualization of gastric wall and surrounding vessels. It also improves detection of liver metastasis and provides vascular information important for surgical planning. For example, surgeons can assess the relation of tumor to arteries like the left gastric or splenic artery. Three-dimensional CT or 3D CT adds great diagnostic value. It visualizes tumor invasion and stomach morphology intuitively. It also provides virtual endoscopic views, helping surgeons understand the spatial relationships between the tumor and the nearby organs. In short, 3D CT improves diagnostic confidence and preoperative planning. Proper distension of stomach is very important for clear evaluation. We typically use a gas-forming agent to expand stomach before scanning. This helps to visualize the mucosa and gastric wall layers clearly, allowing accurate assessment of the depth of invasion. Modern CT workstations can create visual endoscopic images and transparency renderings. Virtual endoscopy mimics real endoscopy, showing the inner surface of the stomach. Transparency rendering allows simultaneous visualization of the gastric wall and adjacent organs, which is very useful for surgical planning and education. Another method we sometimes use to distend the stomach is by having the patient ingest 500 to 1000 milliliters of water. The optimal patient positioning depends on the location of the tumor for better visualization. Next, I'll talk about CT of gastric cancer staging. In this slide, I will show the TNM classification. The definition of primary tumor, lymph node metastasis, and distant metastasis are clearly described, and the overall stage is determined according to these categories. This slide shows the table of clinical staging of gastric cancer. You can see that we just differentiate T2 versus T3 and T4A versus T4B for primary site. And the most important is to diagnose distant metastasis M1, that means contraindication of surgery. Early stage cancers classified as T1 show focal thickening of the inner layer and a visible low attenuation stripe in the outer layer. This is a key sign we look for. For T2 stage cancer, which invades the musculus propria, we see focal or diffuse thickening with transmural involvement. Importantly, the fat plane around the tumor remains clear. In more advanced T3 or T4A stages, the tumor invades the serosa, showing the irregular or nodular outer border. This often correlates with a more aggressive disease. T4B cancers invade adjacent organs such as the pancreas. On CT, we see obliteration of the fat plane between the gastric tumor and the nearby organ, indicating direct invasion. We also have to know a special subtype of gastric cancer is rhinitis plastica or serous carcinoma, known for its high malignancy. It shows a unique enhancement pattern, double-layered in the early phase and single-layered in the delayed phase. The nodal stage is determined by the number of metastasis lymph nodes. CT evaluation of lymph nodes relies on both size and morphology. Nodes are considered suspicious if they show short axis diameter larger than 8 mm, irregular margins, heterogeneous or marked enhancement, or central necrosis. However, we must remember that small nodes may still harbor metastasis, and some enlarged nodes are just reactive. So we always interpret CT findings in clinical context. In gastric cancer, the M stage is determined by the presence of non-regional lymph node metastasis or distant organ metastasis. CT is effective in detecting distant metastasis. The liver and the peritoneum are the most common sites. In the portal venous phase, we carefully check the liver lesions. For peritoneal metastasis, we look for small nodules, omental thickening, or ascites. CT also helps in identifying lung or bone metastasis when present. This CT image is a coronal view, allowing visualization of the stomach in the vertical direction. A mass is seen beneath the gastric cancer, representing peritoneal dissemination. In summary, CT is essential for staging of gastric cancer. Iodine contrast is required for optimal visualization. 3D CT further enhances diagnostic accuracy. CT provides comprehensive preoperative information and supports individualized treatment planning. Thank you very much for your attention.